I will be speaking about functional brain reorganisation in complex regional pain syndrome, and there should be a couple of V's around the word reorganisation, and hopefully that becomes apparent as we go along. Not many people in this room will need to know that complex regional pain syndrome is characterised not only by pain but by the presence of numerous other signs and symptoms in several categories. It's debilitating, it is persistent, it usually affects the upper limb, and although there is certainly a paucity of longitudinal, certainly prospective studies, it would appear that about 5% of people who fracture their wrist go on to develop CRPS. So that's the incidence we think we're working with. Why do we talk about the brain when we talk about CRPS? Well, as with any other chronic pain disorder, there's numerous reasons, but in CRPS there's particularly some interesting ones. Signs and symptoms appear to spread in a non-dermatomal pattern, suggesting something central, including spreading to the other limb in that sort of mirror fashion. And as with a lot of chronic pain disorders, the relationship between the severity of the original injury and the pain experienced by the person is rather a tenuous relationship, and that relationship becomes looser and looser as time goes on as well. Aside from the signs and symptoms, though, there are interesting perceptual abnormalities that have been found in CRPS. CRPS patients have been found to mislocalize tactile stimuli that's delivered to their affected hand, so they're reporting on other sites that feel as if they have been stimulated when they haven't. And this is associated with the presence of mechanical hyperalgesia, so with pinprick stimulation. These people also have reduced tactile acuity, so a task like two-point discrimination, they're quite poor at performance, they have poor performance. And then they report distortions in the mental representation that they conjure of that affected limb. They report it to be larger than it is, or it feels larger than it is in reality, so they know it's not, but they perceive it to be. So it's these perceptual abnormalities as well that have led people to investigate the role of the brain in this disorder. So it seems that what we have in front of us is a misrepresentation of the body, or something that has gone awry with the way the body is represented in the brain. And obviously the physical body is represented many times throughout the central nervous system, but the most widely studied, and certainly what seems to be the most accurate or representation of the body, is in the primary somatosensory cortex. So here is shown in blue in the postcentral lobe, postcentral gyrus is the primary somatosensory cortex, and here is a bundle of cortical neuronal territory that is dedicated to representing our body's surface. And so it's often depicted in an image like this one, or like this one, showing the disproportionate representation of territory according to our function and our need. So here's the hand taking up a large space in S1. And this is shown in a flat plane, but it's not. It's in an XYZ plane, and the thumb and the little finger form the boundaries of the representations of the 5 fingers. So what you'll often see, if you turn to the literature in CRPS and look up cortical reorganisation or brain function, you'll often see words like maladaptive plasticity or reorganisation, and you might see this image. This is from a study that was conducted in 2003, and what I've done here is circled and highlighted the difference between hemispheres in S1 in this patient. So representing the affected hand, the representation of the hand has gone to half the size of that of the healthy hand. And it appears, you can't quite see it in that other image, I apologise, but it appears that the representation of the hand has shifted, or is closer to, the representation of the lip, which sits, the hand and face sit next door to each other in S1. And this has contributed to, at least, cortically targeted treatments in things like CRPS. So treatments like this are theoretically targeted at influencing pain levels sort of from the top down, is the phrase you often hear, rather than going at the limb, influencing our perception of the limb, the painful limb, and thereby our pain levels. So you see things like mirror boxes. So as a group, we wanted to know the state of the evidence. Have many other studies found what Mayhoffner et al. Found back in 2003? We embarked on a systematic review and meta-analysis, and you'll see that we called this paper S1 function in complex regional pain syndrome rather than reorganisation or representation, because not all the studies had a paradigm or a question similar to that one that we just looked at with the mapping the representation of the fingers. They also looked at activation levels with stimulation of the part, or latency, the time it took the message to get from the stimulated part to the brain. So we called it function. Looking just at those studies that mapped representation of the hand by stimulating the first and fifth digit or median and ulnar nerves, we did find consistent evidence of a smaller representation size of the CRPS affected hand as compared to the healthy hand, the unaffected hand. So similar to the diagram, the picture I just showed before from the 2003 study. What surprised us somewhat though was there wasn't as much out there as I had thought there was. We found four studies with a total of 33 CRPS patients, and as well as quantifying the data that came from these studies, we also looked at the quality or the risk of bias in these studies. And as with a lot of neuroimaging, unfortunately, we did find some risk of bias, namely due to lack of blinding in analysis and questions regarding the sampling of these groups. CRPS, I don't need to tell people who work clinically, it's pretty hard to define what some people might call CRPS, some people might not. None of these studies had used fMRI. The four of them had used magnetoencephalography or electroencephalography, and these just have different spatial resolution to fMRI. It's actually inferior to fMRI. And what we also found was they were comparing between hemispheres largely, these studies. They were comparing between the affected hand and the healthy hand in S1, and not with a healthy control group. So we embarked on our own study. We investigated the size of the representation of the CRPS affected hand in S1 using fMRI, and we hypothesised that we too would echo these studies using a different modality with fMRI, and including healthy pain-free controls. We thought that we too would find this smaller representation of the affected hand compared to the other hand and to healthy controls. So we recruited 17 participants for this study who had clinically diagnosed CRPS of the upper limb, so they were sent to us by their treating clinician or pain clinic, and then we had 16 healthy controls. We also then did, because we were interested in what different definitions of CRPS diagnosis, we also did our own independent assessment and diagnosis of CRPS according to the IASP research diagnostic criteria. I won't go into the depths of this today, but if anyone would like to ask me afterwards, I'd be more than happy to chat about that. And we also administered questionnaires on function largely and self-efficacy as well. There's the imaging protocol for those who are interested. This device here, we basically administered a non-painful vibration in the flutter range to the thumb and the little finger of the right hand and then the left hand. So there were 2 sessions of 15 minutes each. The stimulation was in a pseudo-randomised block design. So the thumb went on one of those little speaker-looking devices and the fifth finger on the other. So both hands and a structural scan as well to co-register each patient's data to their own structural image. So the highest activation within an area that we had predefined in S1, based on coordinates reported by previous work on where D1 and D5 should sit in S1 roughly, with 2 standard deviations as well. So we pre-specified that area within S1. And then mapped the distance between the blob that activated from stimulating the first digit and the blob that activated from stimulating the fifth. That distance was then mapped in XYZ space. It's often called a Euclidean distance, and this was used as a measure of hand representation size. It's basically the consensus is that's the best way we have of mapping the hand representation size. And it's important to note here that we were careful to blind this, informed by our systematic review. So the person who collected all the patient data and knew who was not the person who analysed the brain images. So they were I did the half the brain imaging analysis and someone else did the other half, and we didn't know which side was affected or if indeed if it was a patient or a control. What did we find? What we found, oh good, you can see it. I've written affected and unaffected, and that corresponds to the hand. So the affected hemisphere represents the affected hand, if you will. So in red is digit 1 and in blue is digit 5. And what we did find was that the affected hand was smaller in its representation size than the healthy hand in the patients. This is a representative patient, I should add, and a representative healthy control I'll show. They showed distances that were reflective of the means of the samples. So the affected hand was smaller than the healthy, but what fascinated us was when we brought in the comparison with the healthy controls, first of all, we found a difference in the representation of the two hands in healthy controls. So we found that the dominant hand in the controls was larger, on average, than the representation of the non-dominant hand in the controls. So we already had a difference in the control group. Then what we found was when we compared the representation of the affected hand with the controls, dominant or non-dominant hemisphere, we found no difference. What we found was that the healthy or unaffected hand was larger in its representation than the controls, statistically so than the non-dominant hemisphere as seen there. So what we were finding was it was the healthy hemisphere, or that the healthy hand in our patients, which we implicated rather than the affected when we brought in the healthy controls as a comparison. So here's the group data here, just showing a statistically significant difference between the affected and healthy hand in the patients, and also between the controls. But the difference between the two groups arose when we compared the healthy hand, so the second one in there, with the controls. And on the left, sorry, that is distance in millimetres in that XYZ space. Because we found that difference in the controls based on dominance, we're very interested to see, is this a dominance thing? Are these results, is this difference in representation of the hands in CRPS dependent on dominance? So we performed a sensitivity analysis whereby we removed the patients who had their CRPS in their non-dominant hand, and they were the minority of the group. So we took those patients out and ran the comparison again. What we found was that the basic pattern remained. You can see slight changes there, but we've still got the unaffected or the healthy hand implicated here, and that it is larger than the representation of the healthy controls, rather than there being a difference between the affected hand and the controls. We found no correlation between the size of the representation of the CRPS affected hand and their pain intensity or their pain duration in these patients. So again, what we've got evidence of from our work is a larger unaffected or healthy hand in S1 as opposed to a smaller CRPS affected hand when we compared with controls. These results seem independent of dominance despite there being a difference in healthy people that we found. Seems not to be related to pain. And at first you think, why is this so different? But it doesn't necessarily conflict with the existing literature. If we look to that existing literature that I mentioned, we actually only had 2 studies that reported on healthy controls, and one of those studies statistically compared patients with healthy controls. And they used a different paradigm to us and different technology to us. So there's numerous things that could explain it, but this doesn't necessarily fly in the face of those past studies. Equally, not that many studies, we assumed they had when we first turned to the literature, but not that many studies had actually reported on a correlation between pain duration or intensity and hand representation, let alone found a relationship. So I think that assumption on my part came from the fact that more of that is perhaps reported in phantom limb pain, but in complex regional pain syndrome, we didn't find a lot out there. So what might be going on here? The first thing we've sort of thought about is perhaps it's compensatory use. That seems intuitive, it seems sensible. If you've got a hand that you're not using a lot because it's painful and it's got CRPS, perhaps you're using the other one more. And based on what we know in animals and in humans, we do have a use-dependent, that's why it's neuroplasticity, it's functional, it's adaptive. So that's something we're embarking on now, and I hope to present that to you in the not-too-distant future. But we're looking at, is the extent of the S1 enlargement of the healthy hand associated with increased or compensatory use in response to the disorder? Now, hindsight is a wonderful thing. We didn't collect that much data on the healthy hand in these patients. We collected a lot on the affected hand. But what we did collect was overall measures or global measures. So what we're thinking of doing here is inferring compensatory use of the healthy hand, because if we know about their reported use of their affected hand, and if we know about their overall function, how they're managing every day using questionnaires that are pertinent to not just one hand but their overall function, and if we find out a bit about how they manage their everyday tasks through measures of, say, self-efficacy, perhaps we can infer that they're using their healthy hand more. This is still in the pipeline, as I said. And we'll also look at whether that apparent enlargement of the healthy hand might be related to duration of CRPS, because that would make sense too. But what we will do with this is standardise our hand representation size according to healthy controls, because of that difference we found between sides in healthy controls. So we'll need to make sure we do that as well, based on dominance. So all up, the results of the study basically do not implicate that the representation of the affected hand is different to controls, let alone do they imply that cortical reorganisation has occurred or is indeed pathophysiology, a part of the pathophysiology of our subjects. So that's why I sort of said this in our heading at the beginning. There's certainly a need for longitudinal studies. Our systematic review revealed a huge a paucity of that, basically, not imaging someone on two occasions, basically, before and after treatment, or even just with time. Without that, we can't really say that something's reorganised, I would argue. The perceptual investigations is something that needs to be done as well. I think when we look to the literature, there's a lot of correlating findings with hyperalgesia or two-point discrimination, but perhaps looking at the way these people view their limb, perhaps how they perceive one side of space over the other. There's interesting findings in that too. That might help us make a bit more sense of what we're finding in these somatotopic frames of reference. So it certainly called us to rethink the pathophysiology of CRPS, and that picture that I showed earlier from the 2003 paper that we do see a lot, especially given that therapies have stemmed from this sort of cortical reorganisation or a shrunken hand in S1 and CRPS. And like a lot of studies, I think it's thrown up a lot more questions than answers, but I don't see that as a negative necessarily. I don't think that this means we're doing everything wrong. I think it means we have to think, what might we be targeting when we find anecdotally that a mirror box or graded motor imagery therapy or two-point discrimination might be helping someone. Oops. It's feasible that we may just be thinking of different reasoning behind the efficacy of those treatments. I certainly wouldn't say that it's time to throw them out. So we've got a lot of thinking to do, but that's where the study's left us, and like I said, I'd love to come back and talk a little bit more about what we find in terms of compensatory use. This was the team that worked on the study I've just presented. My supervisors were Lauren Mosley, James McCauley and Tasha Stanton, and then we collaborated quite closely with teams all over the place, and I certainly couldn't have done it without them, or the participants, or my funding. Thank you very much for your time.